Hi everyone, my name is Reza Fakhraei. I'm a third-year medical student at the University of Toronto, and I'm honored to be able to present to you what my team has been working on, which is a machine learning approach to COPD exacerbation identification and readmission risk quantification. Start with the background. As many of you are aware, COPD exacerbation are a common cause of hospitalization. About 1 in 4 patients admitted with a COPD exacerbation are readmitted to hospital within 30 days of discharge for any cause. These readmissions are associated with worse outcome and increased mortality, and COPD exacerbations also have non-specific signs and symptoms, which can lead to a delay in the diagnoses and in providing evidence-based care, which can also lead to worse outcomes. So we hypothesized that predictive analytics could assist with the early identification of COPD exacerbations and readmission risk prediction. And our objective was to generate a machine learning model to identify individuals admitted for a COPD exacerbation and stratify them based on their all-cause 30-day readmission risk. We performed a retrospective analysis on 64,609 admissions to general internal medicine at UHM between 2012 and 2018. We processed patient lab, med, demographic data and employed multiple algorithms to generate multiple machine learning models. We then compared the metrics and selected the one performing the best for the final model. Of the 64,609 admissions, 3,620 patients were admitted for COPD exacerbation, and 673 of these patients were then readmitted within 30 days for any cause. Table 1 is our demographics table, which is essentially showing that individuals admitted for COPD exacerbation tended to be older and they were more likely to be male, lower income, and were more likely to have certain comorbidities like heart failure and depression. Table 2 and figure 2 show the identification of COPD exacerbation model metrics, which perform best on gradient boosting, while table 3 and figure 3 show the 30-day readmission risk prediction model, which perform best on logistic regression. Figure 4 shows which features were more important for identifying COPD exacerbation, which ended up being certain medications being used within the first 72 hours of admission, age, sex, comorbidities the patient had. We also saw that after the first about 4 to 7 variables, there was diminishing significant change to the model with no significant change after the 20th variable in terms of relative weight. And this is all demonstrated in figure 5. So in terms of our findings, we were able to generate a model to identify COPD exacerbation with high accuracy, relatively high positive predictive value, moderate sensitivity, relying only on about 4 to 7 variables. And we generated a 30-day readmission risk calculator with relatively high accuracy, moderate positive predictive value, but low sensitivity. We hope to use our models to alert providers early to consider COPD exacerbation. And since our readmission risk calculator runs similar to existing generic readmission risk calculators like LACE and hospital scores, we hope to also utilize it to target scarce resources to those highest risk of readmission. Our primary limitation is small positive sample size, with only about 5% of our total patients having COPD exacerbation and only about 20% of those patients being readmitted within 30 days. We're also missing non-coded clinical data. And so to mitigate these limitations, we hope to use undersampling and expand our database with Gemini. And we also hope to eventually use natural language processing to capture some of the non-coded clinical data. Thank you for listening. And if you have any questions, feel free to reach out to myself or my PI, Dr. Robert Wu. Our emails are in the bottom right. Thank you very much.